Thank you, Stephen. So that will conclude our presentations for today. And now we will move into our panel discussion. And so for that, I will turn it over to Melissa Parisi, my colleague at NICHD, to be able to lead us off.
Thank you, Anastasia, and thank you to all of our speakers this afternoon. I think the presentations have been very timely, clear, and in some cases provocative in a good way. And we hope that this will be helpful and stimulate the discussion that will follow. I wanted to remind folks that for those of you who are listening on the live stream, if you have a question that you'd like to raise to the panelists, the address is listed on the screen, NSIGHT@nih.gov. We are standing by and monitoring our inbox here for questions that you may have, so please avail yourself of that. While we're awaiting questions coming from the audience, I'd like to introduce our panel members and make sure that everyone, actually what I'll do is I'll call on the individuals and have you introduce yourselves and tell us which institution you represent and your affiliation. And then we'll go ahead into the panel discussion. So we'll start with Alan Beggs.
Thank you, Melissa. I'm Alan Beggs. I'm a PhD molecular geneticist and co-PI of the Baby-C study together with Dr. Robert Greene at Boston Children's Hospital.
Great, thank you. David Dimmock.
David Dimmock, I'm a clinical and biochemical geneticist, and I am at Rady Genomics in San Diego.
Thank you. Cynthia Powell.
I'm a clinical geneticist at UNC Chapel Hill and co-PI with Jonathan Berg on the NC Nexus project.
Thank you. Jennifer Puck.
Hello, I'm Jennifer Puck at University of California, San Francisco, and I'm the co-PI of the NBC project along with Barbara Koenig and Pui Kwok.
Thank you. And Renata Gallagher.
I'm a metabolic geneticist at the University of California, San Francisco, and I've been working on the NBC project at the University of California, San Francisco with the team.
Thank you. So in starting off our discussion today, we thought it would be worth taking a sort of a step back to when we first conceived of this program and these projects and really readdress or think about where we've come and whether or not we've answered the three questions that were actually posed in the original request for applications that was published back in the early 2010s. And specifically, the three questions that we were interested in answering through this program were as follows. Number one, for disorders currently screened for in newborns, how can genomic sequencing replicate or augment known newborn screening results? Number two, what knowledge about conditions not currently screened for in newborns could genomic sequencing of newborns provide? And thirdly, what additional clinical information could be learned from genomic sequencing relevant to the clinical care of newborns? So just wanted to ensure that those questions were on everyone's radar screen as we progress. And I think one of the rewarding aspects of this program from NIH's perspective is just how different each of the projects has been and how each of the projects has tackled a component of each of these questions in a little bit different way with really different results. So from the perspective of a pilot program to try to answer these really challenging questions, you all have really taken charge of the issues and really been very successful in your approaches to addressing them. So at this point, we'll open it up for discussion.
So this is Alan Beggs. I could start out. I'll just tell you that, at first blush, I think when we read the RFA and the questions NIH was asking, the question in our minds was, could genomic sequencing actually one day replace traditional newborn sequencing or screening? And I think very early on, we kind of discarded that and said that, traditional newborn screening has certain criteria in terms of sensitivity and specificity, making sure that you don't miss many cases, making sure that you don't have false positives. And it's functionally based. Based on biochemistry, you're analyzing the level of metabolite in the blood, you're analyzing the end result, and so you are closer to the clinical features. I think our thoughts about DNA-based testing are that it's not going to achieve, at least under current circumstances, the same levels of sensitivity. We're not going to be able to identify all the cases or as many cases, and we are likely to have false positives, so we're going to have reduced specificity. So the question really becomes, at what level do you find the optimal balance between those two competing interests, sensitivity and specificity, and how do you use that really, I think, to augment newborn screening results? How can you use that to help potentially identify some cases that might have been missed, or to demonstrate additional information such as information about prognosis for a child, or hopefully eventually specific information about therapies? Other panelists have any thoughts?
Sure, I want to add that we have learned that DNA can't replicate the results that we get from tandem mass spectrometry, and really that, as you say, it's different information. And I think we've seen in our project that it's really complementary, and it can help determine whether someone is affected, a carrier, or unaffected. So it's an additional piece of information, and there are multiple limitations, including, in some cases, not knowing all of the genes that might have caused an elevation of a particular metabolite. That may be one limitation in our data set, not covering the whole gene, not regulatory regions, not knowing all changes that cause disease, or not knowing the effect of those changes. I think one issue that's come up that I think about is when our pipeline, we had a requirement for 2 variants, and we know that we don't always know when 2 changes are found if they're from different chromosomes, one from mom and one from dad. And it was interesting to hear from the earlier presentation that that doesn't happen that often. So it's helpful to have many pieces of complementary information from this project.
I think one of the things that we've seen dramatically is how sequencing can allow you to get to a definitive answer for an abnormal newborn screen. I think the success of California's program in looking at cystic fibrosis is sort of a poster child for that, but also children that fail the adrenal leukodystrophy screen and end up having Aicardi-Goutieres syndrome that you pick up on genome, kids with an elevated C3 that you've got 40, 50, maybe 60 genes that can cause that, getting to a definitive cause and being able to plot treatment and provide families with clear answers. This is what your child has, and your child is on the correct, or they do need this, or they don't need that. So it's one of the things we anticipated, but it's really exciting to have seen it play out over the last 5 or 6 years.
And this is Cindy Powell. I would certainly agree that the genome sequencing is not going to be as sensitive as traditional newborn metabolic screening. But I think that, one case that Tamara had presented earlier, the malonyl-CoA decarboxylase deficiency child, was a preemie in our newborn intensive care unit. And, as those of you who have dealt with newborn screening in premature babies, there's often a need for repeated samples. And, this child had about 4 samples sent to the state lab over about a 1.5-month period, and each one kind of coming back borderline and equivocal. And although this case happened to be an infant with 2, homozygous for VUSs in the gene, that we had to report as VUS because it just hadn't been described before. That specific variant hadn't been described before in a patient with this very rare condition. But I think as we accumulate more knowledge over the years, we will be able to, utilize the genomic piece to help figure out these difficult cases in newborns, specifically with the preterm infants.
And this is Jennifer Puck. So I think over the past 5 or 6 years, we've really seen a sea change in that newborn screening programs across the country did not use DNA sequencing extensively or even at all before 5 years ago. One of the things that actually brought DNA technology into many of these labs is the newborn screen for SCID, which is based on T-cell receptor excision circles, and actually that is a biomarker that isn't a sequence-based test at all. It's just a single PCR test for is it there or is it not? And yet, in order to do that test, the labs had to start making DNA from dried blood spots. And then that opened the whole area of sequencing. And one of the early things that our project had to do was demonstrate that you could do a whole exome or a whole genome sequence from a tiny punch from a dried blood spot, and you could get results that were equivalent to whole fresh blood. And so once that was clear, then the DNA platform is available, and then we have to think what's the most effective and the best way to use it. And just as when tandem mass spec was introduced, and all of a sudden there were many, many different conditions you could identify or try to identify by looking at different peaks there. And some of them had better justifications than others in the realm of the traditional reasons to do newborn screening, that things have to be newborn onset, urgent, medical emergency, treatable. Those kinds of considerations didn't necessarily apply equally to all the things that you could look at in tandem mass spec. And similarly, when you start doing sequencing, you find that you can detect things that aren't all in those urgent, reportable, treatable kinds of realms. And I think we've heard today about how you can sequence things but not report them. And you do have to think carefully about what the goals are and what the context is for the sequencing that's being conducted.
And I think that's a really good point, Jennifer, in that 5 to 6 years ago when we were launching this program, being able to sequence from a dried blood spot was not routine or standard of care or even feasible in most respects. And that was one of the barriers that we identified when the program was first launched. And in addition, genetic or DNA-based testing was not traditionally utilized in newborn screening state programs. So all of those things have really evolved at the same time that the NSIGHT program has been working and producing its results. So I think the timeliness is really remarkable. I wanted to follow up with you on one of the comments that was just raised, which was if we think that genomic sequencing can either augment or complement traditional metabolite-based newborn screening, what do you think would be the next steps for trying to implement genomic sequencing in the context of newborn screening programs?
I'm happy to start that firestorm. So, I mean, I think one of the things that, and I'm going to answer a bit of question B first because I think it's relevant. One of the things that we've realized is that actually having a diagnosis of disorders that fall outside of our traditional biochemical treatable disorders, there's relevance, for example, seizing children that have de novo mutations in genes for which there's a different seizure medication. So it shifts the paradigm of the way we think of things being treatable. As to the question of how do we get there, newborn screening is a system, it's not a test. And to me, I think we could, I mean, the numbers that I think Alex Kemper said was there's 120 conditions that currently meet all of the advisory committee standards that you can pick up with DNA that you can't pick up with analytes. Genomics England data looks like it's more like 200 to 250 conditions that fall into that category. So the fundamental problem now is not can we screen for conditions and even set really stringent criteria for avoiding false positives, because that's actually the thing we're worried about. The problem is, do we have actually anyone to catch the babies? And so I think the big challenge here is actually the rest of the system. The test is feasible to go live tomorrow, but there's not a system in place to catch the babies.
Well, so this is Jennifer Puck, and I want to push back a little bit because I think we need to be very cognizant that the core of newborn screening is a public health mandate, and it's considered so important that we don't require explicit parental consent to do this. We think it's so urgent that we detect conditions like PKU very early, that we conduct newborn screening on all babies. And I think this category of disorders has to be kept in mind. And when we do depart from that, we have to recognize that we're departing from it and be sure of the context of what we're doing. And so I think one context is if you have a sick baby in front of you, as the Rady program has shown us so well, the genomic information can be life-saving and certainly change management. But that's when you start with a baby in front of you who is sick and who needs a better diagnosis. If you are looking at newborn screening in general, where there are vast numbers of nurseries full of almost all healthy babies, that's not the case. And then the issue of false positives and also just discovering things that maybe aren't so imperative as the core screen conditions. That is something that I think perhaps parents should be more involved in the decision to pursue. And those don't all necessarily have to be pursued right at 2 days of life when that newborn screen is obtained. And I think we could think about different ages and stages, and pediatric care is conducted through a child's life, and what is the best stage, and then what's the best time to engage parents in thinking about it.
Yes, I think you're making a very good point that newborn screening, traditional newborn screening, is really focused on large populations of mostly healthy infants right at birth, and that there's a role for that, but that genomic sequencing really serves a much broader function. I think one of the things that BabySeq has tried to explore is the potential risks of getting uncertain information about a healthy child to parents, and we've seen minimal to no evidence for harm associated with that. But there's certainly a concern, and I think that maybe the North Carolina group would like to talk about their concept of age-based sequencing, because this is something perhaps that, in other words, staging the examination and reporting of genetic information over the course of a child's age to be appropriate to the risks and potential benefits that somebody of that age would experience.
Sure. So this is some research that Jonathan has been doing with his postdoc, Lana Mollison.
Is Jonathan Berg?
Yeah. Sorry. Jonathan Berg.
And can you introduce yourself as well?
Yes, my apologies. I'm Laura Milko, and I presented some of this information. They published it, I think, late last year, and really thinking about targeted sequencing in terms of being able to provide digestible packets of information. I think it was either Bob or Flavia who mentioned that one of the comments that parents and potentially clinicians had made was that if there's a choice, then maybe you should say no. And these are just the kinds of things that we're trying to prevent by offering relevant panels at appropriate time stages. And I mean, this is not to say that I'm certainly becoming more convinced by Rady's data and Stephen's excellent presentation about diagnosing ill children, but for actually expanding newborn screening in healthy newborns, I think we really need to think about how to prepare parents to receive this kind of information, how not to create patience in waiting. And this is also not to say that potentially when children reach the age of consent and become adults, that they couldn't opt to receive a genome or an exome. But really the question is, how are we expanding current newborn screening as we know it to be useful? And I think to do it at targeted times when it's relevant to the child's development, and pediatricians and parents can really understand its relevance at that particular moment, is imperative.
So having said that, and I actually like that concept quite a bit, but I think another consideration we need to take into account is that in traditional medicine, there's a one-to-one relationship, doctor-patient relationship between these two individuals, and the physician is thinking only in terms of the potential benefits and risks to their patient. But in genetics, you have to think about the patient as really being the family. And so in BabySeq, for example, we identified infants who carried a cancer risk allele that wasn't going to impact that individual until they became adults. However, most of these conditions being inherited, there's obviously the implications for parents. And in several cases, with parental consent, we actually returned the result to the family that the parents were indeed at risk. And so I think you have to consider that with genetics, we're thinking about more than just the one individual under consideration. Renata, did you want to?
So this is Renata Gallagher from the University of California, San Francisco, and this is a great discussion. I just wanted to address a couple of points in answer to Melissa's question. To me, it seems one of the things we have to decide to do first as we think about employing this is deciding about a technology. So we've discussed that our project was exome slice and that maybe there would be a different way to do this. I mentioned another paper in which there was a different initial technology. The other is a gene list. I'm very struck as a metabolic geneticist when we look at the timeline and we think about the 2006 paper in which the ACMG proposed the initial candidates for newborn screening. We thought of methylmalonic acidemia as just related to a few genes. There are actually 26 genes, at least, that can cause elevated C3 MMA. We know there's another gene that can cause elevated phenylalanine that's only been described in the last 2 years. Tango2 deficiency, a newly described disorder, can probably be identified through this. So we really have to look and vet a gene list. I think we have to have more knowledge about causative variants. And this is the ClinGen project is a very important part of this, and a CSER project expanding information about other populations. We have to be able to interpret variants because we found that there were 30% novel variants. We have to think about how we want to use it as a primary or secondary screen and whether we might do that differently depending on the condition. And I guess the last point is personnel and workforce, which should really be the first point probably, all the way through the system, which Dr. David Dimmock mentioned. There's a small-ish workforce in genetics and a lot more that we would like to be able to do as we have more and more conditions that we can identify and as there's actually more treatment for these disorders. So it is a huge systems that has to be addressed.
So I wanted to sort of step back in again. You know, we have current criteria for how we add conditions to newborn screening. I don't think those need reinventing. I actually think they're reasonably good. There are challenges with them, but there's challenges with the UK's criteria as well. I think as we think about newborn screening, we should be applying those same criteria. If we have an acceptable test that is cost effective, we have an acceptable test that is cost effective. We have to define what that is. As I said, minimum there's 100 conditions, probably more like 250 that we can get off of a genome sequence that would meet both cost effectiveness and all of the other newborn screening criteria. So I don't think we need to be worrying too much about what we do with a 2-year-old. We have children that are needlessly dying of conditions that we could detect by sequence-based screening today. ALDB, hereditary fructose intolerance, would be a good example of this. Many of those kids either end up needing a liver transplant or dying of something that you can get with probably a three or four penny test. And so the fact that we aren't screening for these conditions because we're scared about sequencing, to me, is foolish when they meet current criteria and we can test for them cheaply. And yes, we can get more data from a genome, but there's actually a lot of data we could get today that is relevant to a newborn with diseases that they're going to get in the first 30 days of life. And I think to let babies die because we're too worried about what might happen when they're 2 or 5 or 20 misses the point. But if there's nobody to catch the babies, it doesn't matter if we make a diagnosis.
In thinking about, did you want to say something, Dr. Gallagher?
Sure, this is Renata Gallagher from the University of California. I just wanted to add, too, that I think as we into new disorders, the paradigm of phenylketonuria is always helpful to think about newborn screening because we know that there are variants that we can't interpret, and we need to be prepared for this. That's an additional, really, workforce and interpretation challenge. And I think that it's important to be aware that there can be difficulties for families and physicians with information of uncertain actionability. So benign hyperphenylemia, for example, is a good example of a condition that can be identified on newborn screening, and it was not clear whether this needed treatment. In some cases, we still don't have, there can be clinic variability in what people think about how people should treat individual conditions. So I think it's important to be aware that there will be some uncertainty going forward.
As most of you know, there's a process for nominating and reviewing conditions that are proposed for addition to the recommended uniform screening panel. And that process is basically adjudicated through the Advisory Committee for Heritable Disorders in Newborns and Children. Part of the process for reviewing nominations is really to not only ensure that there is a validated test, that there has been a pilot study done on a population basis that shows benefit, but also that there is the public health impact is reasonable and one that shows net benefit over potential negative aspects. So I'm just wondering if any of you have some thoughts on approaches that might be valuable to address some of those concerns, particularly the challenges that a lot of the state newborn screening laboratories have around how will we deal with the huge influx of data that could potentially come from a genomic-based approach to newborn screening. How will we have the personnel and the staff to actually interpret and utilize these data in a positive manner, and the general feasibility and impact of the possibility of increasing or utilizing genomic sequencing in a newborn screening laboratory setting.
I think the question is, how much of the potential of genome sequencing do we want to try and access? And if you want to talk about trying to learn anything about everything, then it's a tremendous amount of work. The test itself is a single test. And so with one experimental manipulation, you get information about a large number of our genes. So there's not additional marginal cost associated with adding the analysis of one more gene the way there is for a mass spec test where maybe you need to alter the parameters and have a different biochemical test. But as you implied, the cost comes in the interpretation and the analysis there. And the low-hanging fruit, it's actually not that much work to do. We've been talking about issues of sensitivity and specificity. And if we're willing to accept that we're going to be identifying a relatively smaller percentage of cases, but with a high certainty, that's not so hard to do by just limiting ourselves to genes we know a lot about and where we can identify a variant as being likely to cause disease. If we limit our region of interest in that way, it's fairly straightforward. We can learn a whole lot more information about a lot of genes than we currently do. But then we're going to be missing a number of cases. So we just need to accept that reduced sensitivity comes along with greater utility.
Thank you.
Can I
And
just
we'll-
add?
We'll try to deal with this.
Okay. Hopefully we can get the phone line.
Somebody desperately has a question.
Oh. Okay, sure. I was just going to add, I don't think, Jennifer didn't show these slides, but we did that analysis in the NBSeq project of trading sensitivity and specificity, looking, for example, only at curated variants, and really, so we were talking about sensitivity, but also a huge issue is specificity. And I don't remember the numbers, I'm trying to find the slides, but what was it?
So we found that if we used a highly curated list of variants about which we were quite sure that they would be disease associated, then the sensitivity plummeted to 55%, but the specificity equaled that of mass spec pretty much. So yes, we could do that.
So finding half the cases of a whole bunch of things that we could never test before, but for which there's benefit for finding, I think is actually a pretty useful goal. David, I see you shaking your head.
Yeah, and I think just from a bioinformatics point of view, it's really easy because you just make it a lookup table. If X, then Y. You generate a report. You recognize you're going to miss kids, but if you've got that data available and the kid ends up in the hospital, you've got the data available. So a whole lot faster than sequencing the kid de novo. So I think the reality here is screening is exactly that. It's screening. We have kids that are needlessly dying of conditions that we could detect right now with the lookup table approach. And if you're sequencing the kids and you're collecting the data and you're collecting the outcomes, you can then actually learn more about the genetics as you go forwards. But at some point, we have to bite the bullet and start sequencing the kids. And I think saying we're just going to sequence 3 or 4 genes, we miss the opportunity to learn more about those genes. So not necessarily, the data's available for the kid in the future, but this cohort of kids, 10,000, 100,000, 1 million kids that are sequenced, you get longitudinal data. You see if they die, you see if they end up in hospital, and then you can actually start to understand what the penetrance of things like long QT syndromes are.
I think a lot of newborn screening labs are already utilizing next generation sequencing, right, as part of their regular protocol for second or third tier testing. So the idea of expanding that, I think, is definitely within the realm of possibility. Yes, it's going to take additional resources to do that. Whether every single state newborn screening program will be able to do it, I guess I envision more of a perhaps centralized way of doing more, genome level screening. But I do think it's happening. I mean, a lot of the new conditions, for MPS 1 and Pompe disease, XALD, you have to utilize sequencing, or it's very beneficial, to come up with a final diagnosis, and to leave it within the newborn screening system is critical, because many states do not support genetic testing for Medicaid patients. And there's no point in screening a baby when we can't give the family a final answer. And the only way for that to be equitable is if we do all of the testing from the first screening method to the last. And if that's, genomic testing, we need to be able to do that.
Yeah, it's Robert Greene from Boston. In listening to all this, we very much in Boston, I think, focused on item C up there. What additional clinical information could be learned from genomic sequencing relevant to the clinical care of newborns? And not so much on A and B, but it's hard to avoid talking about the state-mandated newborn screening system because it's the only coherent system in America where you can actually get hold of all the children and look at them at one place in time. If we had a more coherent system for public health in other domains, you could imagine doing this in a very different way and reserving the newborn screening system for what it was originally meant for and what it's done so well, which is the acute care of time-limited, urgent, life-saving kinds of situations. Given, however, that this is the situation, it's a really interesting question. How far do you expand that mandate? And we're all aware of the different advocacy organizations that are trying to add things to the newborn screening things that are in many cases are outside of that acute care purview. So, I don't know, just to pick one, familial hypercholesterolemia. Would you add that to newborn screening, knowing it has no relevance for immediate care, but yet in childhood, being aware of it certainly could, and it might be the only chance in childhood that you're picking those up in a public health way. So we can create thought experiments like that really push us to try to understand what are the boundaries of these different systems and where we're missing a system that would actually allow a more coherent elective type of preventive kind of testing.
So I'm going to push back in saying that familial hypercholesterolemia isn't relevant in childhood or infancy, because if the parent has it and they drop dead, that actually really hurts the child. So this is one thing we have to remember, is that kids are typically born into families that are biologically related to them. And so that actually is quite important information. I actually think we've done a pretty poor job of the last little bit of C, which is clinical care of newborns. We've talked a lot about incidental and secondary findings that may be relevant in later life. But we haven't really looked at things like aminoglycoside-induced hearing loss. And so it's been one of the interesting things when we talk a lot about secondary findings and looking for these lists in adults. We haven't actually thought about pharmacogenetics, pharmacogenomics of newborns. We haven't really thought about hearing loss. We haven't thought about things like pathology and how that plays with valproic acid. And so I actually think we've done a pretty poor job of thinking about additional clinical information from a genome that is relevant to the clinical care of newborns beyond a primary diagnosis.
Well, just to be clear, I'm very much with you on that. I think that's clear. No, but I'm asking sort of what, the systems as they're set up and are really set up along those acute lines. But so putting it a different way, David, do we try to push to expand or redefine a component of the existing newborn screening system to encompass C, all the things you're talking about, all the things I'm talking about? Or do you say that's not going to work, that's a different, one's a banana, one's an orange, and we're going to try to set up a different kind of system that would allow children to be electively sequenced with their parents' permission for all these other potential health benefits?
So, showing my true newborn screening stripes for a second. I don't think many people who are in the newborn screening space went through the deployment of SCID screening completely unscathed. Certainly, there was a period of time when certain communities in Wisconsin completely dropped newborn screening because they didn't want SCID screening. So they completely opted out of screening completely. And that led to intellectually damaged and dead kids from the other conditions that we could detect. If we do things to newborn screening that risk hypothyroidism, PKU, MCAD, and maybe a couple of the other fatty acid oxidation defects, we do a huge disservice to probably 400 or 500 kids a year in the US whose lives are saved by that. I worry that part of our problem with vaccines is we have so many vaccines now, people don't see the really vital ones from the not so vital ones. And so my huge worry with adding more to newborn screening is that people actually don't get the kids screened for the conditions that we can really make a big difference about. And I'm going to be honest and say that I think Pompe and X-linked adrenoleukodystrophy are going in that direction. I'm not saying they're there. And one of the interesting things is the advisory committee says a condition meets criteria or not. It doesn't. There's no real system for ranking what actually should be implemented first because it's more important. And I know that's in the eye of the beholder a bit, but I'm really worried that we blow up the whole newborn screening system if we try and put too much onto it. I think if you use sequencing for conditions that we can treat, and that data is available, and parents want to electively go back and look at it in the cold light of day with a reconsent, kind of like what they're doing in Cambridge with their acute sequencing protocol, I can think about that. I would entertain that, but I'm scared that people would stop screening.
Hi, I'm Charlotte Hobbs from Rady Children's Institute for Genomic Medicine. In terms of the processes for newborn screening, I just think back to before we had universal hearing screening or screening for critical congenital heart disease. And when we did introduce those at a population level, then we did have to introduce new processes. So although they all go to the public health departments in most states, and if you look underneath the hood, then in those public health departments, they are handled by very different groups, and the staffing is different and the follow-up is different. So it wouldn't, if there was, not that I'm advocating for whole genome sequencing at a population level, but there is precedent for it to be a completely different system outside of the ones that are currently available for the metabolic screens.
So I agree with you, and I also agree that the newborn screening programs we have enjoy a huge amount of public trust, and we have to preserve that trust. And that is what enables it to be a universal program, is that the public supports it with us, and they appreciate the value of finding these urgent conditions early. And so we have a lot of buy-in for those reasons. Another very important thing that I think Cindy also brought up is the idea of fairness, that newborn screening is for everybody. You don't have to be of means. And I think it's fine to have sequencing initiated and opened up to rich people first because they are already taking advantage of it. But I don't think that we should take our eyes off of the fairness issue in the population-based screening context. And so that means, as Dave Dimmock has said, you need a whole system, not just a test. And even if we could sequence everyone, we can't now follow up everyone. And I don't think it's right to have only wealthy people follow it up and have the rest of our population left behind.
Can I just, this is Ingrid from Boston, just kind of build on that or reiterate that. I mean, I think part of it is you're going to detect all sorts of new diseases in children. You need to have health insurance, you have to have medical care, and so tell someone that they're at risk for something and then don't give them the opportunity, they don't have the opportunity to do something about it because they don't have the insurance and the, you know, the other infrastructure kind of in our current kind of health system. That's also kind of a matter of kind of justice and fairness also, which kind of feeds into that.
Richard?
This is Richard Pfirrman from Brigham and Women's in Boston. I just, as someone who's been a newborn screener in a past life, I just wanted to point out that each of the 50 states determines what their newborn screening panel will be. And so there's no federal, even the RUS panel is not a mandate for a state to do anything. And historically, each state has, based on the beliefs in that state, the financial status of that state, have chosen to do different things. And I think one maybe hopeful example is the story of cystic fibrosis newborn screening, which we started in 1999 in Massachusetts, and was actually the first use of DNA in newborn screening. And this sort of concern was raised then about being forced to do DNA testing. So some states chose to not do it, and some chose to use an algorithm that didn't use DNA, and some chose to go ahead and use DNA in their testing. I think the model in Massachusetts has been successful because it doesn't rush right into a mandate with a new technology. It introduces a new test as a pilot, and each parent gets to choose whether they want to have that pilot done on their newborn. So there are potentially mechanisms for introducing sequencing. The 4 pilots disorders going on in Massachusetts right now all involve DNA sequencing, and there's about an 80% acceptance rate of parents to test for those disorders. So each state could choose to do their own thing, and each parent could choose to do their own thing. And then it takes time for us to generate data to show that it's useful and make people comfortable that they're not having the wool pulled over their eyes. In Massachusetts, it took 10 years for CF from the initiation of the pilot to converting it to a mandate. So I think actually looking at those kinds of models, we could introduce sequencing into newborn screening and let the states and the parents choose at what speed to adopt this as we're generating more supportive information.
Robert?
Well, if we agree for the moment that the newborn screening program, as it's written now, is a sacred trust, it's got good social justice legs, and we don't want to mess with it because we don't want to, then how do we go about introducing even the top layer of potentially life-saving elective genomic information into the lives of children? What's the first step? Do we have to wait for an expert group within the pediatrics community to say the price has come down to $100 for doing 10 genes and good interpretation, and we now recommend that every pediatrician should send to that? It's $100. It's still not going to be socially just for everybody, but it's a lot more affordable. Do we wait until it's somehow state systems are invented to subsidize it? I mean, somebody draw me a blueprint for how this gets started in a way that respects the value of the information, but is also acceptable from at least a moderate social justice point of view.
So Robert, there is a mechanism, and I think it's pretty similar in each state, which is each of those 50 states has an advisory committee to their Commissioner of Public Health. And then you need a champion.
Oh, but you're talking about the newborn screening, right?
If you want to work within the current system.
I'm talking about actually in putting this outside the newborn screening system, a whole new system for screening children through genomics. I mean, you've convinced me for the moment to stay away from the newborn screening because babies will die if we mess it up.
Right. So for one thing, it's universally mandated in pediatrics that somewhere around their first birthday, a child needs a hemoglobin and a lead level. And I think this is nearly universally done. Pediatricians all know to do this, public clinics do it. And this is a time when babies, even if they don't get a whole lot of regular medical care and checkups, are going to be encountering the medical system to get this done. I actually think that is an opportunity. That's a time when the family can think about consent in a calm, environment that's not just having had a baby. And I think we should really pursue whether that could be a time. I'd love to have another NSIGHT batch of funding to look into, could we look at 1-year-olds as a target for some of these things which might have a bit later onset?
Yeah.
We could make a huge difference. We could use the new technology and we could get buy-in.
Love it. That's a great idea.
At the risk of contradicting myself, which I often do. The challenge we have is that, when you look at this list of conditions that I think Alex talked about a couple of advisory committees ago, the list that Genomics England has, the list that's on the NIH website of conditions that meet current criteria. That's to say they have onset in the first 28 days of life. There's an accepted treatment that is available. There's a test which is sequence-based. It's all good and well talking about what we're going to do when a kid's a year old, but we have kids needlessly dying right now. And if we're going to sequence the kids and we're going to look for 130 conditions, to be honest, doing whole exome is probably actually just about the same price. So I don't think that we necessarily have to have the generation of the sequence data and the interpretation of that sequence data connected. There are conditions that we need to know about in the first week or two of life. There are conditions that we need to know about within the first few months of life. There are conditions, and so this issue of longitudinal records that are tied to you as an individual, yeah, you can solve it with things like Bitcoin that just get crazy. But most states get called by athletes to get their sickle cell trait status. So the newborn screening lab is actually used to this recontact from families. It's clunky, it doesn't work great, but there are informatic solutions to this. So I think we can sequence kids at birth, look for what's relevant at birth, and find ways of keeping that data tied to that child.
I want to come back to follow on your point, David, to ask then about specificity. So would you accept then a lower sensitivity, and how would we determine that for a higher specificity so that we don't have the burden of false positives? For PKU, we missed, and MCAD, we missed 5 to 6% for each in our cohort. And we would say that that would be unacceptable. So we would do tandem S spectrometry for MCAD and PKU because it's better than DNA sequencing. And as Melissa pointed out, this is done gene by gene, disorder by disorder currently on the RUSP. How would we retain the public's trust and be sure that we were working within our own, sufficient knowledge to go forward for an individual disorder that you might choose on that list? If you have an example, for example.
Can I actually quickly respond to that? I mean, Renata, I think you're making a presumption that there is a better test available. In the course of PKU, there is this available screening test with high sensitivity and high specificity. I think a lot of the conditions we're talking about are conditions for which there is no biochemical test, no other better test. So then you accept lower specificity, lower sensitivity, and your limit has to be how many false positives are you willing to accept.
But that's actually exactly what I'm asking, Alan.
Yeah,
because
set your specificity and then see what your sensitivity is, and you just have to accept that, whatever it is.
That's fine, but I guess what I want to add here is just the public trust, because then you are going to sequence, you are going to look for disorders knowing that you're not going to be able to identify everybody.
Well, all the time now, we return results, negative results to families and have to explain to them just the fact that we didn't find something doesn't mean you don't have it. And that it can be a difficult concept for many people, and it does need explanation to some extent. But I don't see any way around that.
But I think, again, such an important point of what we've discussed here is the difference between a phenotype and the absence of a phenotype. And newborn screening is done in the absence of a phenotype. And there's no relationship really between the screening. It's automated. And so there's no physician there. There's no context. There's no counseling.
And the parents didn't ask for it.
Exactly.
So I think there are ways of handling that. I think you can say, OTC, some states actually say they screen for it and they miss more than they find. probably they find about 1 in 10 kids with OTC and miss 9 out of 10. So we're doing this currently. We just pretend that we're not missing kids. We miss PKU when they're premature. But the deal here is that if a child gets sick and you have the ability to look at the data again, the public trust you have is to say, this is a screening test. We're going to miss a lot of kids. This is better than what we're currently doing. And if your kid ends up in the hospital, we can look at the data again. Then you maintain the trust that, and I think getting to the social justice issue here, if I can just step on that pedal again, the most common urea cycle defect in the world is citrin deficiency. It's really common in East Asians. We don't screen for it because it needs a DNA test. There are certain conditions that are common amongst certain people groups that cause them a lot of problems that we don't screen for because we don't have enough cases to set standards, but we know what that population's found the mutations are and their treatable conditions. I think the enemy of good is better, and I think we just, to misquote Voltaire, I think we have to get over the fact that we're going to miss stuff. We miss stuff on newborn screening now. It's life. If we pretend that we're not missing stuff on newborn screening, you haven't sit through enough flagged cases.
I think that, we just don't know whether this is going to be a good thing or not. It might be, really beneficial and save lives, but we just don't know, especially at a statewide level. When we first started tandem mass spec, we had, at least 2 statewide pilots in Massachusetts and North Carolina that showed this was a good thing. We picked up and saved the lives of, many children with MCAD who otherwise would have been missed and died. But we had that data, from statewide pilots. And I think, and also with, that expansion with tandem mass spec, because most states weren't offering state-level newborn screening, there was a commercial lab that offered it, and that was direct-to-consumer testing. I mean, grandparents were buying it for their newborn grandchildren and things like that, and eventually it expanded to states being able to do it. So, I really think probably there will be some innovative states that take this on and do pilots and provide us with the information. But I would hesitate at this point to say, that it would be a good thing to do on a population level.
Can I just ask you, if I understand what you're saying correctly, in a thought experiment, if you could do it cheaply and you could, as people have talked about, reduce your sensitivity to get very, very high specificity and using only variants that are well associated, moderately highly penetrant for diseases of childhood that are actionable in even a conservative sense of the term, you wouldn't apply that to a population at this moment in time? Mm-hmm.
No, because I think, we
I know
don't,
that's a fictional situation,
Yeah,
thought experiment.
Well, we just don't know enough about it, right? I mean, we don't know what it's going to take. We don't know what the penetrance is. We don't know what the, follow-up is going to entail, who's going to explain this information to families. It may be something that, the primary care providers will be able to do and do the appropriate follow-up and everything. But, I really think we need more data before we go down that path.
Well, the devil is in the details, and there's a tremendous heterogeneity in the issue that we're grappling with, I think, is you have to go gene by gene. But there are so many examples of really well understood conditions. And so, for example, if you have a deletion of your dystrophin gene on the X chromosome, we know you're going to have muscular dystrophy. And we now know that there are things you can do early on that are going to help. So that's a subset of findings that you could make that would lead to direct intervention. We heard today that for phenylketonuria, that's not necessarily the situation. So finding variants there, we're not certain what the outcome is. So we don't go there. We don't report those on a population level. But my sense is that we've gotten to the point where there are so many knowable things that can have benefit that people have to understand there's no guarantees in life, there's no 100% certainty on anything, and that we're going to be missing things, but that we still can identify and report things where we're highly confident of the implications for what we have found. And I don't see much reason to wait on that other than to establish what those things would be.
So I think what we learned from Pompeii, or what we learned from pretty much any new condition that we've added, hearing loss, is that the piloting in a couple of states to learn where you're going to stub your toes, and once again, newborn screening is a system, it's not a test. And so you need to figure out what you need in place to catch the babies. And so trying that out somewhere first, and I do think you have to actually probably go gene by gene, condition by condition, because the individual that follows up a spinal muscular atrophy is different than the individual that follows up a long QT. And so getting them into clinic is different. So I do think there is an element of piloting gene by gene, but the thing is, if you're getting all of the genomic data, you actually can start to understand penetrance on your historical controls that you have the genomic data on, that you also have 1, 2, 3 year phenotype follow-up.
I think, David, I would agree with you that it would be ideal to have a system that was ready for all that complexity, but I don't think we have one. And so then the question becomes, if you believe, as I do, what Alan just said, that there is at least a subset of genes and variants that we are fairly certain would have a great deal of positive impact on children's lives, how do we give it back? How do we test for it, and how do we give it back? What other system, and I agree, it should be a system, do we put in place? So let's take Jennifer's suggestion for the 1 year mark. What if you, just to be speculative, what if you said, we're going to do a pilot where children have an opportunity to, their parents have an opportunity to send for a relatively inexpensive panel of however many genes, 20, 50, 100, and look only for high specificity, fairly high penetrance variants. And that's gonna go into effect with that. And the information will come back to their pediatricians. You're right, some of them won't know what to do, but some of them will figure it out. Could we get behind that?
I think when newborn screening works is having the expert on the phone with the pediatrician, who then conveys the information to the family, and then they follow up with the expert.
Would you endorse that kind of pilot?
That kind of an approach. I would love to try this out, and I think we should be trying this and saying,
Would other people at this table
we should try
endorse
this
that kind of pilot?
as a newborn. We should try this at a year. We should try this at 5 years. We should see we don't know what the optimal time to return a BRCA1 result is. There's some suggestion that if you grow up always knowing it, it's less stressful than suddenly catastrophically finding out when you're 20.
But as you just pointed out, it's a lot better for the affected parent to know it than lose that parent.
So the only way to do this is to do some real science that requires follow-up.
So on that note, since I think we're at the 5 o'clock hour, I want to thank all of our panelists and participants who led to a really robust and rich discussion. Thank you for your time. Thanks to those of you who phoned in and joined us on our live stream. And stay tuned for further results and outcomes from this very productive collaborative set of projects. Thank you.